Right now. Okay, we're recording.
Okay. All right, so we'll do it a little bit informal because we're a small group today. But I thought we would start with some basics. So I'm going to do this part a little bit quick because you know it or you know some of it. So we'll get a chance for some questions about this. So this is just the basics of the heart, which you're all aware of, the two atria, the two ventricles, the valves that go in there. And I did it, hopefully it's going to show up relatively close. So this is the heart with the electrical system. So the rest of it is ignored for the most part. The electrical system of the heart it's kind of fascinating, but it's also relatively straightforward. The SA node at the top, do I have a cursor? I don't know if I have a cursor. I don't. So the SA node, the sinus node, is the starting point. It's at the top of the right atrium, and that's kind of where the internal pacemaker, the main internal pacemaker, every level of this actually has redundancy, and everything could be a pacemaker at a slightly slower level than rate than the level above it. So the sinus node heads and depolarizes the atrium, heads down to the AV node that has a built-in delay function, while the electricity kind of collects and gives the blood a time to move from the atria to the ventricle. And then once it comes out of there, it goes through the His bundle and then splits into the left and right bundles, which is what we're here to talk about today, the bundle branch blocks. So the bundle branch block is kind of interesting, but before we get into it, we're going to talk about where it hits the EKG. So we'll start with the basic of the EKG. So in the middle, you'll see a bundle branch block. If it's a full bundle branch block or an incomplete bundle branch block, you'll see it in the QRS duration and the QRS shape. So the QRS is wider if the bundle branch isn't functioning normally. All this I just put in EKG because I like to talk about EKGs. So a normal QRS duration is less than 100 milliseconds, so 2.5 boxes. And a full bundle branch block is more than 120 milliseconds, so 3 small blocks. 3 little boxes is what we're looking for. So it's the width we're looking for and the confirmation of it. Question? No, you're just no. Perfect. Okay, good. So we always start in the EKG thinking about the basics, and so when we're getting down to bundle branch blocks, we're actually looking at the QRS complex, so it's more than just the basics. So we figured out the rate and the rhythm and whether it's sinus or not. Not that it matters. You can have AFib with left bundle or sinus rhythm with left bundle. It's all the same, but we kind of work our way down through there to the QRS complex, and that's where we come into, okay, is it a bundle branch block? What's the axis? What's the duration? All that sort of stuff. This one was a big winner last time, so I thought I'd throw it in there again. This time the localization of the leads, the general areas that things work in. The interesting thing about bundle branch blocks is with all of these leads that are out there, you're mostly interested in leads V1 and V6. That tells you kind of what you're looking for. I don't think, oh I did, okay, I did put the next one in. Can we go back up?
Move your arrow. There you
I want to
go.
move the arrow.
Now just click. There you
Okay.
go.
So, V1 and V6 are the ones that you look at for the most part, answer most of your questions for bundle branch blocks. But it's always nice to think about what leads we're looking at. You know, the anterior leads, the septal leads are the biggest one, and the lateral leads. And most of it is because the issue with bundle branch blocks is that you have 2 main fast, now I do want to go ahead, 2 main fast conducting areas, the right bundle branch and the left bundle branch. So this is just from the AV node down. This is just the bottom half of that picture. So what happens normally is the electricity is conducted very rapidly down the fast parts. Can you don't see my curve? Yeah, you do. Down the main trunk. So down the main trunk of the right bundle is pretty much just like a big copper wire until you get down to what's called these terminal Purkinje fibers. And that's where it actually makes real contact with the muscle cells. And likewise on the left side, it does split. We'll get into a little bit with the anterior and the posterior fascicle. But it goes down these big bundle branch blocks pretty much instantaneously, and then out to the fascicles here, the Purkinje fibers. What happens in a bundle branch block is if it was right bundle, you have either no conduction or very slow conduction relative to the left bundle branch block here. Electricity goes down the left bundle, and then once it gets down to these Purkinje fibers, it gets into the cells, then it goes cell-to-cell contact where it activates the right ventricle through cell-to-cell, which is slower than going through the Purkinje fiber. So instead of the right and left ventricle happening, getting electricity and squeezing simultaneously, you have it go down to one side, squeeze, and the electricity then works its way over and starts the squeeze later. And that's why the EKG looks wider, because you don't have two things happening at the same time, you have two things happening next to each other, and it takes longer. And distance on the EKG is time. So the interesting thing, and this is where I get a little bit geeky with EKGs. So the interesting thing about the left bundle branch block, where did my arrow go?
Oh, it's around there
I
somewhere.
don't think it is.
There you go.
Is this little thing right here. So this is what's cool about EKGs. There's actually a ton of information that a lot of smart people figured out. So this is the septal Purkinje fibers, which you'll notice come off of the left bundle, not the right bundle,
For most people.
for almost all people. And so if you really look at an EKG and you look at that on V1, you'll look at there's a tiny little R wave before a Q wave. And that R wave is the septal activation, and it's because it's coming from the left side of the septum, on the left bundle, towards the right side of the septum and activating that way, which is why in V1, that little thing is upright for the septum, and in V6 it would be downward, because it'd be going towards V1 and away from V6. And so you actually lose that in a true left bundle, you lose that little R wave in V1 and that little Q wave in V6 because you don't have that little conduction down this little one right here, which is always an interesting thing. And then you think that's super interesting and you get all geeked out on it, and then you find out that in the real world, nothing's pure or true, and there's lots of these little things that still show up, even though it's pretty much mostly a left bundle. So bundle branch block. So this gets patients all the time say, oh, it's a blockage. What do you mean a blockage? I've got a blockage? So it's really better to think of it as a delay or non-conduction down an electrical fiber. So you wouldn't say that you've got a blockage in your house wiring if you didn't get electricity there, disconnection or some bad switch or something like that. So that's what it is. So it's not a blockage in the arteries, it's a blockage in the electrical system or a non-conduction, or even just a fairly significant relative delay from one side to the other, such that it got to the other side and started doing the work through the cells before it ever happened. Normally, the ventricles are very synchronized. Even though these bundles are a little bit different length, it's so fast that it doesn't make any difference. The lights come on both sides of the room at the same time. It's kind of that fast. Left bundle branch block. This is the one that the headline of the title. This is what everybody wanted to hear about. Left bundle branch block. But if I talked for an hour about left bundle branch block, probably all of our hearts would actually literally stop because it would be so boring. So left bundle branch block, to summarize this slide when you look at it, left bundle branch block is almost never normal. It usually means there's something wrong. You may not ever find exactly what it is, but something's wrong. In very few, less than 1% of a healthy general population. And this is, they look at new recruits into the military, and they look at Scandinavian countries where everybody is on a public electronic medical record basically, and they've looked at thousands of thousands, hundreds of these statistics come from 350,000 young recruits were had an EKG or something like that, and very, very few people have left bundle branch block as just a normal person. Not zero, but almost none. And it's usually you've got something, and it's usually it goes up with age, it goes up with things that affect the heart otherwise, high blood pressure, cardiomyopathy, coronary disease, that sort of stuff. You can see it transiently, or maybe it's worsened compared to baseline with electrolyte abnormalities, myocarditis, or other inflammatory things which are not very common. It doesn't mean it's symptomatic. Most of the time people with left bundle don't have any symptoms at all. that gets caught on an EKG because they're pre-op or they're just in for an annual with somebody, and then we go and we look and we see if we can find anything. Most people end up getting an echocardiogram, and then a good history. We don't often go and do a whole bunch of other testing if the echocardiogram is normal and they don't have a cardiomyopathy without any other symptoms. If you're young and you have a left bundle, it by itself probably doesn't relate to an increase in mortality, but as you get older, it's probably an indicator of enough other comorbidities that you might have an increase in mortality. 2 to 3 times risk is what some of the studies have shown, but that's in people who have other things that raise their mortality, like coronary disease, heart failure. So compared to other people with coronary disease, somebody with a left bundle and coronary disease does have an increased mortality. We don't exactly know why. It's probably just an indicator that things are just that bad. So here's the left bundle branch block, and it's really pointed out there. It's like radioactive in the middle there. So electricity doesn't get past that point. So electricity goes down the right bundle normally and then works its way through the cell, the myocardial tissue itself, over to the left bundle, and so, or over to the left ventricle. So the cells all get activated. It's just, it takes long enough that we can measure it on an EKG. And here's a left bundle. So V1 and V6, it's interesting. You can get the whole answer in V1 and V6. So first of all, for a left bundle, it has to be supraventricular. If it's ventricular tachycardia, it doesn't count as a left bundle. So it has to be something supraventricular. The QRS for a complete left bundle has to be greater than 120 milliseconds. You can have, typically you'll have a QS in V1, and these are kind of little code words we use. QS means there's no R, it's just downward, so Q is down and S is down, so QS is down. Or you can have a little R with an S, which is, you still have a little bit of that septal conduction there. Either way, it's almost all downward in lead V1. It's wider, 3 boxes wide at least, and it's notched in V6. So you have this wider notched thing. And the first part of the notch is the ventricle being activated initially, and then the second part is the left ventricle eventually being activated. The right ventricle first, and then the left ventricle being activated. So you see them, instead of happening simultaneously, they happen next to each other, one then the other. There's always, the T wave goes the other direction. Repolarization is opposite of the terminal force. The last bit of the QRS might be up, then the T wave should go down. That's normal in a bundle branch block. It should always be opposite. So just for reference, I'll give you some pattern recognition when we look at it. So this is a normal EKG. Trust me when I say that, but you'll notice it's narrow. It's up in the leftward leads. You've got normal transition from V1 through V6, where it starts downward on the right side and works its way upward on V6. And then here's a left bundle branch block. It's wider. It's notched in V6. It's clearly more than 3 boxes. Not that we can see the little boxes, but it is. And in V1, you've just got a QS. There's no little R wave. This is kind of a perfect left bundle. The T waves go the opposite way. There's no little early septal thing. It's all downward in V1. It's all upward and notched in V6. Here's those two next to each other. They're a little bit smaller. But I think it's always helpful when you're looking at these patterns to just be able to go back and forth with them. Any questions about what that looks like, doesn't look like?
I got the other diagram. You have like mirror images, like in lead 2, almost, right? So that's inferior. Lead 2 is inferior, right?
Yes. Yep. But 2, 3, and AVF are inferior. So what that's telling you with 2, 3, and AVF being negative is that a lot of the direction of the vector is upwards, which makes sense if it's come down the right ventricle and then it has to go back up to the left ventricle, up and over and leftward, to some degree. So an incomplete left bundle branch block looks like a left bundle, There may not be as broad or as big of a T-wave inversion. The main deal is it's between 100 and 119 milliseconds. It's not all the way to 120 milliseconds. And what that usually means is that if you look at V6, it's not as wide, the notch is not as prominent. And what that means is there isn't as big of a delay from the right ventricle to the left ventricle. So there's probably still, there's some cell-to-cell conduction, but there's still probably some slower left bundle conduction. And so instead of the two things being widely separated, they're just narrowly separated. And so you don't have as distinct a separation between the two activations of the two ventricles.
What causes the actual block itself?
It's more like corrosion. Don't think of it as a block, but think of it as, corroded
Break
wires.
down and then-
Yeah, corroded wires and just bad nerve, same thing as like neuropathy. It's just not good electrical wires, so you don't get good conduction. And a lot of it is related to fibrosis or calcification or scar tissue, wear and tear.
From an MI.
From an MI or from the thickening that you get with left ventricular hypertrophy from high blood pressure, or the calcium that you get around the valves, the valve rings, because if you go back to the first picture, the valves are right here, and the AV node and the bundles go right between those two valves. And if there's a bunch of extra calcium and stuff pushing on there and irritating, it's not a good, it's not a good environment for those kind of touchy electrical cells. And then this has no specific recognized mortality risk. It just kind of, it is what it is, and it may progress or it may not. When we look at a left bundle, we tend to think, well, what do we do now? Well, if they're asymptomatic, you get an echo. Generally, we don't always do Holter monitoring, but if they're truly asymptomatic, you just get an echo and make sure that they don't have a cardiomyopathy that you need to find. I found at least three patients in the last year that left bundle was their indicating for looking at things. They didn't have any symptoms, but their heart function was at, their EF was like 30%, which was pretty far down. If they have symptoms, it depends on their symptoms, how far you go with the evaluation. And echo's involved in everybody. If they've got syncope, then you need a Holter, or you just need to go right to a pacemaker, depending on what's going on. But they probably are not just a left bundle, but they're a left bundle with maybe some jeopardy of their right bundle. And if you lose the right bundle, then you're basically just incomplete heart block. And that may be why they're having syncope. If they've got chest pain, then the left bundle may be affected mostly by ischemia, that sort of stuff. So you just take the rest of it as it goes, and from there you would basically do what you would do otherwise. You get a stress test or a cath, you're treating them with a pacemaker if that's what they need, or further evaluation with a loop recorder or Holter monitors, vent monitors. So this is just a framework to think about it. Basically, the point of this slide is to say a left bundle branch block usually means there's something going on. Use your usual thought process and figure out what that thing is. So left anterior hemiblock or left anterior fascicular block, along with left posterior fascicular block, both of those are not, because you do have at least one good wire to the left ventricle, right? You've got two that split, you've got one that works, one that doesn't, whichever one it is. It's not a widening, but it turns out to be more an axis issue, an axis of the QRS. So it's the direction up or down of the QRS, not the width of it. Because, do I have a good one? No, I don't have a good one, sorry. So, what did that do?
Did you mandate it?
Oh,
No, I didn't. See what I can do.
oh.
It's
All
your
sorts of
overlay.
things.
Overlay. Still overlay.
Undo.
I'm gonna do something. No?
Maybe it's that thing just slow.
No, it looks funny over here too. Looks better. Okay, so the left bundle has two big parts, the left anterior fascicle and the left posterior fascicle, that then branch into their terminal Purkinje fibers. If you block one of them, then what happens is the left ventricle still gets its conduction from the main bundle, but it's either coming from the bottom up or it's coming from the top and the back downward. So the QRS is not wider, it just has a different direction of the electricity. And that's what the axis of the QRS tells you. I put this on here because this is how you tell axis on an EKG, and this is the axis of the leads that are on there. And so what you'll notice is that 1 and AVL are over here, and so typically when you have normal conduction of the EKG, everything is moving leftward, and so 1 and AVL will be positive. Typically it tends to move downward, and so 2, 3, and AVF will often be positive, and those are standard ways to look at it. With left anterior hemiblock, what you find is that it's really leftward. The axis, the left anterior hemiblock is kind of on the top side, and so the left posterior is where the electricity comes from, and then it has to basically come up and really leftward. So the way we describe left anterior hemiblock basically is a QRS axis that's more negative than negative 45. So when you look at the QRS on there, it's going, let me stand up for this one. It's going up on this angle on the EKG, the QRS is, which basically means that it's very far away from 2, 3, and AVF. And so what you'll find is that 2, 3, and AVF will all be negative because it's going this far up. When you're looking at axis, if you're within 90 degrees of the lead, if you're within the 90 degrees, you'll be positive. If you're more than 90 degrees away, you'll be negative. So the direction of the axis and the direction of the QRS tells you which way. The direction of the lead and the direction of the axis. So that gets complicated, and I don't want to get too far into it. What I really want to do is make sure you know that the hemiblocks are not a width, but they're an axis issue, which can be measured, and I'll show you how. So if you think about where you put the leads on an EKG, you've got the 2 arm leads, you've got a negative and a positive, and that's lead 1 from the right arm to the left arm. And so it's going directly across this way. If you put from the right arm to the foot lead, it's lead, and left arm to the foot lead, it's lead 3, and it goes from the left arm to the foot, and the right arm to the foot is lead 2. The augmented leads, you take those 3 leads and you actually put a central 0 spot in the middle, and from there down to the foot is straight down, and that's actually at 90 degrees, and that's AVF, and AVR and AVL are, at different angles compared to that. So it's just an interesting way to look at it. That's the part of the stuff that I told you, if we talk an hour about left bundle by itself, it would stop all of our hearts, because it's that boring. So I'm going to show you a picture of that. So left anterior hemiblock. It's not wide, or it may be minimally wide, but it's certainly not like a left bundle. It's not 120 by any means. The QRS by itself kind of looks sort of normal. It doesn't have any funny weird notches or anything like that. But it's down in 2, 3, and AVF. It's really far down. So you know that since those are the inferior leads, you know that the electricity is going upward. And it's positive in 1 in AVL, so you know it's going leftward. So it's up and left. And interestingly, lead 2 is the one, because it was the one that was on this side. If it's negative in lead 2, then that means actually it's more negative than negative 45, because it's far up in that way. Lead 3 could still be normal, but anyway, that's the interesting thing. If leads 2, 3, and AVF are all negative, and 1 in AVL are positive, you know it's going upward and to the left. And that's a left anterior hemiblock. That's the whole thing.
Wow.
Which is only sort of interesting, mostly on your cardiology boards, because if you miss it, you don't pass the EKG portion. Yeah. And so the interesting thing about left posterior hemiblock is it's kind of the opposite. It's coming, instead of going from this way up, it's from this way going down. So instead of a leftward axis, it's a rightward axis. It's more positive than 90. And if you think lead 1 was 0, and then it went to 90, and then it was 180 is over there until you come back around this way, it means it's really far down. So if the electricity is pointing down, the inferior leads should be positive, upright, coming at those inferior leads. So what you find is that the inferior leads are all positive, and since it's going down and sort of the opposite, instead of up and left, it's going down and right, leads 1 and AVL should be negative. This is one where I kind of want to draw it for you.
I need
Because
like
it's
a
hard
heart in
with
front
words.
of me. I know.
Actually, you don't really need a heart. What you need is this whiteboard.
Here you go.
So, let's see.
I didn't email them to you.
Okay, this works.
I know, but you can't write on it now. Or is he coming up there with it?
So when you look at the heart,
Do you work in this office? No, I'm an ambulatory nurse educator. For Chelsea.
so when you've got the
You print his slideshow.
inferior leads,
Before his slideshow.
2, 3, and F,
I'll show you.
are down here. So if you've got a left anterior hemiblock, you don't get this one, so you get the electricity this way, which means the electricity is going to go that direction. With the left, and so these are going to be positive, or negative, because it's going away from them. With the left posterior hemiblock, you don't get this one, so you get electricity here, and you get the electricity going this direction, the opposite. So the inferior leads are going to be positive. So here's the cool thing, though. So lead AVL is here. And so since if we're going to get it actually this direction, that's more than 90 degrees, I'm just telling you that, from 1 and AVL, so they're going to be negative because it's going downward. So it's really all about which direction these, the starting point of the electricity is in the left ventricle, and then it just goes from there to the other side. And that tells you which direction the vector is and why it's a hemiblock, because it got one, not the other. I feel like the axis thing is a hard part in this one, because we haven't done axis.
It's hard to see jump, like the electricity jumping. I guess I don't know, more of I have to see the muscle pump or something.
It is a little bit kind of theoretical. when you look at it. And just here's a picture of it. And what you see is in lead 2, 3, and AVF, the inferior leads, it's all positive. And in 1 and AVL, it's predominantly negative. It's not all negative, it's predominantly negative. And
Vesicular block is the same as a hemi block.
correct, same thing. Kind of denotes whether you trained on the East Coast or the West Coast, or whichever one you use. So, this is otherwise not interesting. Again, the QRS is not particularly wide, maybe a tiny bit. It may be slightly over 100, but it won't be 120. If it's over 120, you've got some other significant conduction delay that's affected a whole ventricle, one way or another.
The QRS is very short, not tall on V1. Does that have any significance?
Not particularly. It's just the slight variation in which direction the axis is in relation to that lead. So, not exactly. So this one I put in there because it's sort of left bundle-y. So a ventricularly paced rhythm is wide, usually very wide, because there's no bundle branch involved at all. The pacer is just stuck right to the muscle, and it's all cell-to-cell conduction through all of the ventricles. Most pacers are in the front, at the bottom, and on the right side of the heart. this is where we put pacemaker leads. So you're looking mostly, it's gonna show up, the ventricular lead is here. And so it's usually stuck to it's in the right ventricle. It's near the apex usually, not always. It's in the apex, and the right ventricle is, it's in front of the left ventricle. So typically, what you'll see is the QRS is wide, it's leftward, it's upward, and it's backwards. Why did I say that? Well, I'll show you.